Hello everyone, welcome back to my channel. In this video, we will be talking about temporomandibular joint. It's a very important topic and try to watch till the end because I have included questions related to it. So let's get started. Temporomandibular joint is a bilateral, it is a synovial joint. Synovial joint are usually joints which permits wide range of movement, and it is a diarthrodial joint. Diarthrodial also means that it is a freely movable joint. Now, this TMJ is divided into upper and lower compartment by articular disc. We will talk about it in later slides. But right now remember that the upper compartment, it permits translation. The lower compartment, it is for the rotation. Now, the articular surface of the bone are covered by fibrocartilage. Most important line, because in our body most of the joints which are synovial, they are covered by hyaline cartilage, but TMJ is the one which is covered by fibrocartilage. Let's talk about the components of TMJ. So as we go from superior to inferior, the most superior portion we can see in the diagram orange color, that is the mandibular fossa, which is also called as glenoid fossa. This fossa is a part of temporal bone. As we'll go down, we will have an articular cartilage surrounding the fossa. Then we will have the disc. The disc we can see in the green color. This disc will divide into upper and lower compartment. As we go further down, there will be a condylar cartilage cap. That means there is a cartilage which will surround the condyle. And finally, we will have the condyle of mandible, which we can see in the blue color. Let's imagine that this entire joint is surrounded by an articular capsule. The capsule has an internal lining of synovium, which will produce synovial fluid to lubricate the TMJ. And also there are ligaments to stabilize it. This slide is just to give a brief idea about the components of TMJ. We will discuss each and every component in detail in the coming slides. So let's talk about the ligaments of TMJ first. So the medial and the lateral collateral ligaments, they are also called as discal ligaments, and they connect the articular disc to the condyle on both the sides, and this ligament keep the TMJ aligned during any movement. The second one is temporomandibular ligament, which is also called as lateral ligament. We can see in a green color in the diagram, this ligament is found on the lateral aspect of the capsule. It prevents the condyle from moving too far backward, that is posterior, or on the sides. The third one is the stylomandibular ligament. Now the name itself says it runs from the styloid process and it attaches to the mandibular angle. Now this helps in mandibular protrusion. And opposite to that is spinomandibular ligament, which runs from spine of the sphenoid bone to the lingula of the mandible. Now this one, it limits the excessive protrusive movement and excessive jaw opening. So stylomandibular allows the mandible to protrude and spinomandibular protect it from the excessive protrusion. One more important point. If during inferior alveolar nerve block, patient develops facial nerve paralysis, then which ligament could be affected? Is it stylomandibular or spinomandibular? So the answer is stylomandibular, because if we are piercing the stylomandibular ligament, it means our needle has gone too far posteriorly and there are chances of facial nerve paralysis. If it is a spinomandibular ligament, then it might be the right place to inject. We always go lateral to the spinomandibular ligament. So let's talk about the bony components of TMJ. The first bony component is the condyle of mandible. Now, this is elliptical in shape. The long axis runs mediolaterally. Remember, the posterior portion is rounded and convex, while the anteroinferior aspect is concave in shape. The second bony component is the glenoid fossa, which is also called as mandibular fossa. And we have discussed earlier that this is a part of temporal bone. This is again concave in shape. Now, this is the superior most portion, glenoid fossa. And the anterior portion of glenoid fossa, it has an articular eminence that is somewhat like a tubercle that is convex in shape. Now, both this glenoid fossa and the condyle of mandible, they are both lined by fibrocartilage, means they are covered with a dense fibrocartilage and not hyaline cartilage like other synovial joint. Now, let's talk about the articular disc, which is also called as meniscus. So, remember the other name also, that meniscus is disc only. Now, this again is a fibrocartilaginous and it is a biconcave disc. Biconcave lies between two bony components. That is, superiorly there is glenoid fossa, in between there is disc, inferiorly there is mandibular condyle. Let's talk in detail about the articular disc, which is also called as meniscus. So again, this is a fibrocartilaginous and it is a biconcave disc. It lies between the articular surface of condyle and the mandibular fossa. This disc divides TMJ into superior and inferior compartments. And remember, superior allows translation motion, inferior compartment allows rotational motion. Now the disc attaches peripherally to the capsule and anteriorly it attaches to the lateral pterygoid muscle. It attaches to the medial and lateral poles of condyle via collateral ligaments. We discussed this in the ligament, that there are medial and lateral collateral ligaments. Let's talk about the regions of the articular disc. So there is really a thin intermediate zone and there are anterior and posterior bands. The posterior band is continuous with the posterior attachment tissue. This posterior attachment tissue is called as bilaminar zone, and this bilaminar zone is vascular. It is innervated tissue. So the lateral pterygoid muscle, it attaches to the neck of the condyle, capsule and the articular disc of TMJ. So if there is a damage to the disc where the lateral pterygoid muscle inserts, it can render the lateral pterygoid non-functional on that side and the mandible deviates to the damaged side. Talking about the articular capsule, it is a fibrous capsule and it surrounds the entire joint. It attaches superiorly to the glenoid fossa and inferiorly to the condylar neck. So we know from the earlier slide that this capsule has an internal surface of synovium. Synovium will secrete synovial fluid for lubrication. It doesn't cover the articular surface or articular disc. It's just present on the internal surface of the joint capsule. Diagnostic tool for TMJ. For the bony structure, there is always OPG, CT scan or just plain films. However, the soft tissue of TMJ, it's usually MRI. So remember that the best diagnostic tool for TMJ is MRI. Let's talk about the blood supply and nerve supply. So the blood supply to TMJ is by the branches of external carotid artery, principally the superficial temporal artery. Other include deep auricular, ascending pharyngeal and maxillary artery. This is very important. The nerve supply is through auriculotemporal and mesenteric branch of mandibular nerve. Alright everyone, that's it for the TMJ. Let's do some questions. So, the articular disc which separates the articular surface of TMJ is composed of what material? This we have done so many times, that the articular disc is made up of which cartilage? You guessed it correct. So the answer here is fibrocartilage and not the hyaline cartilage. So the next one, double contrast phase arthroscopy is used to study clicking of TMJ, deviation of TMJ, joint space or disc. So the correct answer here is the joint space. So contrast phase is for the joint space. So this is tricky. When a patient is suffering from an unfavorable fracture of body of mandible, what we can expect is that so that the anterior fragment will be displaced downward by the action of digastric muscle, the posterior fragment displaced anteriorly by action of lateral pterygoid, anterior fragment displaced backward by action of temporalis, or the posterior fragment displaced medially by medial pterygoid muscle. So the correct answer here is anterior fragment displaced downward by the action of digastric muscle. So for this answer, remember the elevator muscles of the mandible. And we all know which are the elevator muscles of the mandible, like temporalis, masseter. These are all elevator muscles. They would displace the posterior fragment upward because they are elevator muscles. And the suprahyoid muscles, for example, digastric, geniohyoid, mylohyoid, and stylohyoid, they would displace the anterior fragment downward. So remember, elevator muscle of mandible displaces the posterior fragment upward, and the suprahyoid muscle displaces the anterior segment downward. Alright everyone, I hope you enjoyed this video. I hope we learned together something from this video. And if you liked this video, please like it, share, subscribe to my channel, and see you in my next video. Till then, enjoy studying. All the best.